Okay, yeah. Okay, so we will be reviewing for lecture exam 3. It's going to cover chapter 8, which is joints, and then chapter 9, which is muscles and muscle tissues. Afterwards, I do have a lecture and lab practice exam. So if you're not here in person today, you can come into the SLC Frio 111 and pick up a practice lecture or lab exam. The practice lab exam will be up until next week when the last, or I guess in 2 weeks, when the last lab takes their third practical. For your lab, today we're really only going to be focusing on the lecture portion, but for the lab, it will also cover chapter 10. So, but chapter 10 is mostly muscle identification. So just know that in the lab portion, you will cover chapters 8, 9, and 10. But for lecture, we're only doing chapter 8, which is joints, and then chapter 9, muscles and muscle tissue. So an overview of joints. This isn't going to be like all inclusive everything we learned in class, but like a good breakdown of the more specific broad things you need to know. So what is the name of a site where 2 or more bones meet? Or what do we call it? What is the name when 2 bones do what?
Articulate.
Articulate, yeah. So when 2 bones articulate, we have a joint. So can somebody give me an example of a site where 2 or more bones meet? A kind of basic one is like the femur and acetabulum, or the glenoid fossa of the scapula with the head of the humerus. Exactly. So those are what we call articulations, and then from there we get joints. So with joints, we have 2 classifications. We have functional and then structural. So with functional, we use the mnemonic SAD. So we have synarthrotis, amphiarthrotis, and diarthrotis. From here, the words kind of interchange and we call them synarthrotic joints or amphiarthrotic joints or diarthrotic joints. So just don't get confused if you see throsis instead of throtic. They kind of go back and forth. So synarthrotic joints are joints that are immovable. Amphiarthrotic joints are joints that are slightly movable, and then diarthrotic are freely movable. So this is what we classify as functional. So on the lecture exam, the way it can be asked is, what is an example of an amphiarthrotic joint? That would be a joint that is slightly movable. So after functional, we have structural joints. These are the second classification. We have fibrous, cartilaginous, and synovial. And these are kind of the more like the big breakdown of joints. And this is where we get like the different types of joints. So again, functional, we have SAD, and then structural, we just have fibrous, cartilaginous, and synovial. So with fibrous joints, these are bones joined by dense fibrous connective tissue. Most of these are synarthrotic, which mean what? They're immovable. Good. And then we have 3 types of fibrous joints. These are sutures. Where are sutures found? In your skull. Yeah. So once these are fused, once your sutures are fused, they do not come apart. They are stuck together and they're immovable. Syndesmosis and then gomphosis. Does anybody know where gomphosis are found? Your teeth, yeah, your gums. These are like the alveolar sockets when we did in the bone part or bone section. So from here, what you need to know is fibrous joints, most are synarthrotic, which means they're immovable. And we have 3 types of fibrous joints: sutures, syndesmosis, and gomphosis. And then we also have cartilaginous joints. These are bones united by cartilage. These are not highly movable, which is kind of in between synarthrotic and amphiarthrotic. They don't really move. So it's kind of confusing, but they really don't move. The time in which it moves, because let me go back. We have 2 types of cartilaginous joints. You can't see it. It says synchondrosis and symphysis. Hey, Laura, do you think you can move the like squares on there. It's just covering some of the words. So the types of cartilaginous joints, synchondrosis and symphysis. The symphyses would be like the pubic symphyses that's between the two os-cox of the pelvis. This can sometimes move during childbirth. So that's why it's not highly movable. During childbirth, they do kind of like slide on each other to allow for the fetus to pass through, but they're not highly movable. So is it supposed to move? No, but sometimes they do move slightly. Yeah. These are cartilaginous joints. Can anybody think of another type of cartilaginous joint, which again, bones united by cartilage? Think in your chest area.
Oh, in the
Sternum, yeah. So on here on George, we have the sternum and then the ribs, which are connected via that cartilage right here. And again, these don't move. They can expand, but they don't necessarily move like some of our other joints. And then the last type of joints are synovial joints. These are bones separated by a fluid-filled cavity. All are diarthrotic. And these are like the big types of joints that you need to know for your exam. These are the ones that have the 6 specific types of synovial joints, which are not these. We're going to get into on the next slide. But there's 6 distinguishing features of synovial joints. The first is articular cartilage. Articular cartilage is hyaline cartilage that prevents crushing of both ends of the bones. The second distinguishing feature is a joint or synovial cavity. It's a small fluid-filled space. The articular capsule has 2 layers. It has an external fibrous layer and then an inner synovial membrane. That inner synovial membrane makes synovial fluid. Or I'm sorry, synovial, yeah. And then we also have synovial fluid, which is a viscous, slippery filtrate. And you need to know that it has plasma and hyaluronic acid. Mhm. The synovial fluid lubricates and nourishes articular cartilage. And then we have reinforcing ligaments. And then nerves and blood vessels. The nerve fibers detect pain and monitor joint position. And then the blood vessels or capillaries supply filtrate for synovial fluid. Yes, so the synovial joints are freely movable. So then the next thing to know with synovial joints are bursae and sac or bursae and tendon sheaths that are present. So some images are going to pop up in a bit, but quickly, bursae are sacs lined with synovial membrane that contain synovial fluid. Bursae are responsible for reducing friction where ligaments, muscles, skin, tendons, or bones rub together. So if you can imagine, like on George over here, if we were just skeletal and nothing else, our bones would kind of like click clack on each other all day long, and that would be A, uncomfortable, and B, wouldn't really allow for a lot of movement or allow us to do a lot of the everyday things we do, like throwing a ball or extending, flexing our leg. So those bursae are there to reduce friction. And then we also have tendon sheaths, which are elongated bursae that are wrapped completely around a tendon that is subjected to friction. So here we have an example. This is the humerus right here. We have the scapula, the acromion of our scapula, and then over here would be the what's it called? Glenoid fossa. So we have the bursa, which is right here. This one, green with like yellow in the middle. And it's between the acromion of the scapula and the head of the humerus. Again, because if we tried to throw a ball and we didn't have these bursae, our bones would kind of click clack on each other and we would not be able to throw the ball. Here we have the tendon sheath, which is wrapped around the head of the humerus and kind of articulates with the bursa and protects the bones. So from there, the bursa rolls and lessens friction as we move our arm. So as we are moving our arm or we're throwing a ball, we are raising our arm, the bursa rolls and lessens the friction between the scapula and the humerus. So I would make sure you know the definition and the difference between bursae, tendon sheath, and then I believe I'll probably be jumping back and forth from lecture and lab and kind of telling you what you need to know for lab. I would be able to identify the articular cartilage, the joint cavity, synovial membrane, fibrous layer, and be able to label this image here. Okay, so movement of synovial joints. All muscles attached to bone or connective tissue at no fewer than 2 points. There's one specific bone that does not form a joint. What bone is that? Hyoid, yeah. So the hyoid is the one bone that doesn't articulate with another bone. So that would be where there's no joint there. Some definitions. Origin is the attachment point for an immovable bone. So each bone or each joint has an origin, an insertion, and an action. Right now, we're only focusing on origin and insertion. The origin is the attachment point to an immovable bone. Insertion is attachment to a movable bone. And then muscle contraction causes insertion to move toward the origin. And then this movement occurs along transverse, frontal, or sagittal planes. And then here is an example of an origin and an insertion.
Can you test us, like, which is an origin?
They could ask you, like, what is the origin for the tricep brachii muscle? Name an origin for the tricep brachii, and it would be one of these. So the, what is this, humerus or the scapula? It kind of depends on your professor, but I know some professors will allow or will take humerus or scapula, and like that's good enough to get full credit. I don't know if another professor would want like the actual specific landmark of the bone. So that's, yeah, that may be something you want to ask your professor. But again, make sure you understand the difference between origin and insertion, and then also action, which is not on here, but it's basically just what the joint or the muscle, the bone allows the movement, movement to do. Okay, so range of motion. Let's talk about the types of synovial joints first. So we have 6 types that we are studying for our exam. We have plane, hinge, pivot, condylar, saddle, and ball and socket. The easiest to identify is ball and socket because those are usually the bigger ones. The femur and acetabulum, the glenoid fossa and humerus. There is some really good examples in your textbook, and we just got 2 more textbooks, so we now have 4 in the lab, just FYI. But go through and make sure you can name a type of joint for each of these, and then the movement. So going back this way, range of motion, we have non-axial. These are slipping movements only. Non-axial usually occurs in plane joints. Uniaxial, movement in one plane. This is hinge and pivot. Does anybody know a type of hinge joint?
Your elbow,
Your elbow, yeah. What 2 bones are that primarily?
humerus, and your ulna.
Humerus and ulna, good. So hinge joint movement in one plane. This is what our humerus and ulna do. It's kind of all they do. Biaxial movement in two planes, we have saddle joints and ellipsoidal joints. Ellipsoidal is condylar. It's one of those things where it's called different things. There's so many languages in the world, it kind of gets translated into different things. Ellipsoidal is condylar. And then multiaxial movements in or around three planes, ball and socket joints, or gliding. Gliding would be the motion. Why is a ball and socket joint multiaxial? Like, why does it do so many things?
Because it's like around everywhere.
Yeah, it can move around. We use it to walk. We use it to, we raise our arm to cook, to do everyday things, to write. These are, I wouldn't say the most important joints, but they're kind of the most important because they do a lot of things, or they allow us to do a lot of things.
Also to walk, right?
Yeah. That's what allows us to be bipedal, which means walking on two feet. Other animals or mammals, they do not have that specific movement that allows them to walk on two legs. Be familiar with the movements allowed by synovial joints, images from textbook and lab worksheets. So what I mean by that is the flexion, extension, hyperextension, abduction, adduction, circumduction, rotation, lateral rotation, medial rotation. You're going to want to know which of these joints allow these specific movements to happen. It can be either in a picture form, so they can give you a picture of flexion and ask what type of joint allows flexion, or they can say the blank joint allows flexion to happen. You'll have to identify the joint. And then we have special movements, so supination and pronation of the radius and ulna. Supination, pronation, holding a bowl of soup. Dorsiflexion and plantar flexion, inversion and eversion, protraction, retraction, elevation and depression of mandible, and then opposition of thumb. I would be able to identify all of these by images as well, which I believe are in your lab worksheets.
Is supination for the radius? Or it doesn't matter?
Only the radius moves. So the radius is the one that crosses over.
Radius is the pivot.
Again, make sure you know the 6 types of synovial joints and an example for each. Your book has a really good table and it breaks down the entire skeleton in every single joint and names each type of synovial joint. Okay, so then you'll want to know the different types of joints. I said that, okay. 5 main synovial joints that we cover: the jaw, which is the temporomandibular or TMJ, shoulder, the glenohumeral joint, elbow, hip, and knee. We're going to go through them kind of quickly. TMJ, temporomandibular joint, allows for 2 types of movement. It is hinge and gliding. So hinge, depression and elevation of mandible. This allows you to chew, which then we have to cover joints before muscles, because now we know that since it's the TMJ is a hinge joint, which is depression and elevation, then that's when you get like your masseter muscle that allows for chewing. Gliding side to side, so when you grind your teeth. And then the TMJ is the most easily dislocated joint in your body. That may just be maybe like an extra credit question, or it may just come up somewhere. Your shoulder joint is a ball and socket joint, and it's the most freely moving joint in the body. I can also see that maybe being an extra credit question or coming up. Because it's the most freely moving joint, the stability is sacrificed. So there's some people who their shoulder just dislocates like really easily, and then they just kind of pop it back in. That's because the stability is sacrificed, because your shoulder can do so many things, especially in the people who are like double jointed and they do that ugly thing where they pull their arm behind their head and stuff like that. That's where that comes from. So again, shoulder, ball and socket joint, most freely moving joints, and because it's the most freely moving joint, stability is sacrificed. And here are the types of joints again. The elbow joint is the articulation of your radius and ulna with your humerus. It is a hinge joint which allows for flexion and extension only. And then we have two ligaments that restrict side to side movement of this joint. That's the UCL and RCL. That should be the ulnar collateral ligament, and then the radial collateral ligament. If you've ever heard of like the Tommy John surgery in baseball players, it's this ulnar collateral ligament. And then I may be wrong, but I believe like when you hit your funny bone, it's hitting one of these ligaments. So it's not actually a bone, but you're hitting one of the ligaments that makes it tickle when you hit it, some would say. Your hip joint, the head of femur articulates with the acetabulum of your os cox. This is a ball and socket joint and has good range of motion, but is limited by the deep socket. So because the socket is deep, right, we can't kick our leg and make it go all the way around our body like we can kind of do with our arm. It allows for range of motion in walking or hyperextending, like gymnasts who can do the splits and stuff like that. But it gets to like a certain point where it cannot go farther than what it is. And then our knee joint is 3 joints surrounded by a single joint cavity. So the femoropatellar joint, what 2 bones do we think make up that joint? The femoropatellar.
The femur and the tibia.
Not
No, the patella?
patella, yeah.
Okay.
So that'd be your femur and your kneecap or patella. And then the lateral and medial tibiofemoral joints. What 2 bones do we think this is?
The tibia and
Femur, yeah. So anytime you see joints, right, try to break up the word and you can identify where in the body it's coming from. So again, 3 joints surrounded by a single joint cavity. The knee joint is the largest, most complex joint of the body. The knee capsule is reinforced by muscle tendons, and then these are the ligaments stabilizing the knee joint. Capsular and extracapsular ligaments, they help prevent the hyperextension of knee. The fibular and tibial collateral ligaments, oblique popliteal ligament, and the accrute popliteal ligament are the capsular and extracapsular, and then intracapsular would be the ACL and PCL. And then knee joint injuries are vulnerable to horizontal blows. So the example in the book is a hockey puck, like coming in and hitting the knee horizontally. Your knee will probably give out and you'll fall. And then one of those ligaments will probably be ruptured. So there is a lot of muscle tendons, ligaments, and muscles that kind of hold the knee together, but any sort of twisting or turning, sudden direction change can cause your knee to, one of those ligaments to rupture. So again, I would know that the knee joint is the largest, most complex joint of the body, and then that they're vulnerable to horizontal blows. I was supposed to add something here. The other things you need to know for the exam, I don't remember what is in the chapter exactly. I was supposed to have something, but let me think. I think that was kind of it. I don't remember how long chapter 8 was, but knowing the different types of joints, really focusing on the 6 synovial joints, knowing an example for each, knowing knowing the specific names of the joints. So we're talking about lecture. Try to spell them out when in lecture, and then being able to identify by sight, this is more so for the lab, but by sight, which ones are which types of joints. So looking at like the ones we have back here, you would need to know some of these by sight, and we have a few of them. Okay, and then chapter 9 is muscles and muscle tissues. I'm only going to cover as far as my class has gotten, which we stopped at muscle twitches, I believe. But your exam will cover all of chapter 9, so make sure you go over all of chapter 9. Okay, muscle tissue. So the big thing you need to know is muscle tissue transforms chemical energy, or ATP, to directed mechanical energy, and then exerts force. So it's taking the chemical energy, or ATP, and then directing that to mechanical energy to allow us to perform movements, to do different things, to raise our arm, to kick our leg. And then we have 3 types of muscle tissue that we covered the very, very beginning of the class. What are the 3 types? Skeletal, smooth, and cardiac. Good. The one we kind of focus on is skeletal muscle because we have a lot of bones and it covers a lot of our body. Cardiac muscle, of course, is found only where?
On the heart.
On the heart, yeah. So cardiac muscle is only found in the heart, and then smooth muscle is in around the hollow organs. So just knowing the types of muscle tissues, but we kind of focused on skeletal. So anytime you see myo, mys, or sarco, we are talking about muscle. So these are the prefixes for muscle. And then the 4 special characteristics of muscle tissues you're gonna want to know: excitability, contractility, extensibility, and elasticity. On the exam, it may ask you to like match them. So having the definition, you need to match the word to it, or blank is the ability to receive and respond to stimuli, excitability. So just making sure you know the definitions. Excitability is the ability to receive and respond to stimuli. Contractility is the ability to shorten forcibly when stimulated. Extensibility is the ability for your muscle to be stretched. And then elasticity is the ability to recoil to resting length. So make sure you know the 4 of those. And then connective tissue sheets of skeletal muscle. These support cells and then reinforce the whole muscle, which I'm gonna pull up the picture in a second. And then if we work from external to internal, these are the layers. We have the epimysium, perimysium, and then endomysium. Epimysium is the dense, irregular connective tissue surrounding the entire muscle. Perimysium is the fibrous connective tissue surrounding the fascicles. And I'm going to pull up the picture.
Irregular?
Yes.
Okay.
And then endomysium is the fine areolar connective tissue surrounding each muscle fiber. That is this photo. This is likely to show up on possibly both exams. So again, we have, let's see, here is like a histology slide of what we're looking at. We have a bone, the tendon, and the whole muscle that is attached to the tendon. Because remember, tendon attaches muscle to bone, and ligaments attach what? Bone to bone. Good. So this outer layer is the epimysium, which again is made out of dense, irregular connective tissue. The perimysium wraps the fascicle that's in here, right? This is fibrous connective tissue. And then the endomysium between the individual muscle fibers, which are here. And this is loose areolar connective tissue. I would be able to label this. I can see them like crossing off this part right here and having you label which type it is. Yes. These are characteristics of muscle tissue. I got this from, I believe it was the notes that the professors put on Canvas. If you don't have access to it, let me know. I can email it to you. But basically, these are just the general characteristics, functions, and physiology for each muscle tissue. You need to know the specific characteristics for each, and then understand the similarities and differences between the 3 types. So for example, a question that could be asked is which type of muscle is classified as voluntary? We can see skeletal is voluntary, cardiac is involuntary, smooth is involuntary, so the answer would be skeletal. The basically I would just be able to compare and contrast all of these and just know like the characteristics. Trying to think if there's anything else from here. Another big thing to know would be like the presence of sarcomeres versus no sarcomere, and then where it is they're found. I can also see it asked,
The sarcomeres are only on the skeletal, or are they both on
Mm.
skeletal and smooth
skeletal and cardiac.
and cardiac?
Mhm.
Is that supposed to be tested on cardiac? Or is it only skeletal swab?
I believe,
It
I-
has a little bit.
yeah, I know there's a little bit of smooth that was in the PowerPoint. I don't remember if we talked about cardiac, but it's on here, so it might be. But I know you have a different professor. Okay, that's probably just for lab then, yeah. Okay. So then muscle attachments, we went over this a little bit. Let's see. Oh. The muscles span joints, they're attached to bones in at least 2 places. Insertion versus origin. So an example, the deltoid muscle's origin is the clavicle, the acromion, and spine of scapula. So the origin is in 3 places on 2 bones. Its insertion is the deltoid tuberosity of the humerus. And then there's one more that I spoke about a little bit earlier, which is the action. The deltoid is the primer mover of the arm or abduction. So that would be the action. I know on your lab practical, it's going to ask about the action. And my professor said, not my professor, but he said just knowing abduction would be sufficient for full credit instead of saying like the deltoid is the primer mover of the arm, abduction.
So action, aka abduction.
Mhm. The action, you could just write the one word for the movement.
Abduction.
And then a little bit more on muscle attachments. A direct attachment occurs when the epimysium of muscle is fused to the periosteum of bone or perichondrium of cartilage. We talked about this with the last unit. The periosteum of bone is that outside. So direct attachment is when the epimysium is fused to the periosteum. And then indirect attachment occurs when the muscle's connective tissue extends beyond the muscle and includes tendons or flat extensions of connective tissue called aponeurosis. A few of us have started to talk about that in class or lab. Does anybody know where we find aponeurosis, like an example?
Right here on the top of your
Yeah,
head.
the top of your head or somewhere else. Abdomen, yeah, your abdomen. Good. I would know the definitions of these two, the differences, and then indirect attachments. Yeah. Okay, so then this is where it gets a little funky with the anatomy of skeletal muscle. We're gonna go through it kind of slowly first. This is something that my professor had on the board, and I thought it was really helpful. One muscle, right? We have one muscle is many muscle fascicles. One muscle fascicle is many muscle fibers. One muscle fiber is many myofibrils. And then one myofibril is many sarcomeres. So here, we'll go through it slowly, is that myofibril. And then this would be like that sarcomere.
I really like how you explain that.
Thank you. We can move me later, or I can pull this back up if you want to write it down. But yes, so some basic things to know, the sarcolemma, which is this like little peel back thing right here. It's what is surrounding the myofibrils. That is the plasma membrane, or it acts like the plasma membrane of the muscle fiber. And then it has modified structures, the myofibrils, the sarcoplasmic reticulum, and the T-tubules. Myofibrils are these rod-like elements that contain sarcomeres, and then within the sarcomeres are myofilaments. do not believe they're on here.
They would be in the endoplasmic reticulum.
Yeah, the sarcoplasmic reticula.
Sarcoplasmic.
There's another diagram that's on your lab worksheets that you can see them. I don't think I have it on here though. And then with the myofilaments that are again in the sarcomeres, these are orderly arrangements of actin and myosin myofilaments within the sarcomere. So these are thin and thick filaments. Actin are the thin filaments. These extend across the I band and part way in the A band. So here's that I band, here's the A band. And then the actin filaments, which again are which ones?
The thin.
Thin. These are anchored to the Z discs, which are here. So what is this whole structure?
Sarcomere.
More specifically,
Oh,
a myofibril, yeah. Okay, and then the myosin myofilaments are the thick filaments. These extend the length of the A band and they connect at the M line. So here again, we have the thin actin filament and the thick myosin filament. For the lab, I would be able to identify specific regions on here. For the lecture, I would know the definitions of the filaments, and then knowing that actin is thin, myosin is thick. There's a, I want to say there's a table in your book in this chapter that goes over these specifically, like what exactly these are and what occurs at each. Make sure you go through that. And then again, one muscle is many muscle fascicles. One muscle fascicle is many muscle fibers. One muscle fiber is many myofibrils. And then one myofibril is many sarcomeres. I think this is where a lot of students are having trouble understanding kind of what's going on here. So definitely spend some time in this portion of your chapter, because I'm pretty sure this is going to be what's going to come up a lot in the lecture exam. Okay, this is a lot on here. I try to put everything that was on the notes that's on here, so you kind of have everything you need to know about the neuromuscular junctions. So neuromuscular junction is where a branch of motor neuron contacts a skeletal muscle fiber. And then we have the model of the neuromuscular junction back here. This thing right here. Components of a neuromuscular junction, I'm going to name them off first and then read through them. The axon terminal, synaptic vesicles, neurotransmitter acetylcholine or ACH, acetylcholinesterase, that word, synaptic cleft, motor end plate, and then the ACH receptors. Sorry? Oh, yes. Oh, yes, I'm on it. Yeah, be all right. So the axon terminal is the end of the motor neuron axon. It forms the neuromuscular junction with skeletal muscle. The synaptic vesicles are membrane-bound sacs within the synaptic bulb that contain neurotransmitters. I can see this being asked, where are the neurotransmitters found in the neuromuscular junction? In the synaptic vesicles. Neurotransmitter ACH is released upon the skeletal muscle. It activates depolarization, which is then followed by contraction. Acetylcholinesterase is the enzyme in the region of the synaptic cleft that destroys the neurotransmitter ACH and renders it inactivates it. The synaptic cleft is the space between the synaptic bulb and the sarcolemma of the muscle cell. This nerve does not make physical contact with the muscle. The motor end plate is the specialized region of the muscle cell membrane that contains receptors that bind the acetylcholine. And then the ACH receptors, this is long, these are membrane proteins of the sarcolemma that bind the ACH. When these When the ACH binds to these receptors, this activates openings of the sodium channels of the sarcolemma. The sodium then rushes into the muscle, causing depolarization and then contraction. So the way the professor explained it in class, he had like this big picture on the board, if anybody remembers that. This is kind of like the very compact, simple version of that. It's a lot deeper, which we can talk about one-on-one, but basically the opening of the sodium channels from the sarcolemma, and then the sodium rushes into the muscle, which causes depolarization and then muscle contraction. So this is basically all for muscle contraction. And then from there, we have two main categories of contractions, isometric and isotonic. I do have images that'll come up in a second. Isometric, there is no shortening of the muscle. The muscle tension increases but does not exceed the load, which is here. So the muscle tension increases but does not exceed in isometric. I would be able to define it and then identify it. So if they were to give you this picture right here, it would be isometric contraction. And then isotonic contraction, the muscle shortens because the muscle tension exceeds the load. And then there's two specific types or characteristics. Concentric, the muscle shortens and does work. So when you pick up a book or you're kicking a ball, your muscles are going through concentric contraction. And then eccentric, the muscle generates force as it lengthens. And then both of these, isometric and isotonic, are equally important for coordination and purposeful movements. So on the left, we have isometric, and this is that isotonic contraction, specifically concentric. So we can see that the muscle contracts, and this would be the big difference between the two. I, again, would be able to define the two and then be able to identify it. So if they were to take this top part away, knowing that this is an isometric contraction and this is an isotonic or concentric contraction. And then muscle twitches is one of the last things my class got to talk about. This is the simplest contraction resulting from a muscle fiber's response to a single action potential from a motor neuron. So a lot of the times that muscle contractions are looked at or are tested are within like a lab setting. So that is why we have this graph over here with the different types of periods. And then with muscle twitches, there's 3 phases. I would know the 3 different phases and then the definitions for each. So there's the latent period, the period of contraction, and then the period of relaxation. The latent period occurs when nerve fires and events of excitation, contraction, coupling occur. At this point, there is no muscle response. I can also see that being a question, true or false. In the latent period, there is muscle response, false. So during latent period, there is no muscle response. During the period of contraction, occurs when cross bridges are active and muscle shortens. And then the period of relaxation occurs when Ca++ re-enters the sarcoplasmic reticulum. That is calcium. Something specific with calcium, ionized calcium. But basically when calcium re-enters the sarcoplasmic reticulum, that is the period of relaxation. So another way this could be asked, what is occurring during the period of relaxation? Calcium is re-entering the sarcoplasmic reticulum. This is what it looks like in a lab setting. So here is this latent period, the period of contraction, and then the period of relaxation. This is measuring time and then maximum tension. This was on your PowerPoint. I'm not sure if it'll show up on the exam, but it's possible it might. And this has to do with muscle twitches. Again, knowing the definition of muscle twitch, that it's the simplest contraction method or simplest contraction that occurs. And then it results from muscle fibers responding to a action potential. And then again, knowing the 3 phases and then what is occurring at each phase. And that's all I had for the review. That's as far as my class got. There's still a little bit left in chapter 9, but there's not much. There was a little bit of smooth muscle, and then I think so. There's just a little bit more from smooth muscle, and then that's it. So we do have practice lecture and practice lab exams. The lab exams won't start until next week. And then I know there's one class that's going to take it, not next week, but the following week. So I suggest starting with the practice lecture exam. And then we can go through it when you finish. And yeah, you can email me with any questions. My email is up here. And then the practice lab exam for anybody, or if you're on the Zoom, will be up until not next week, but the following week. And if you have any questions, just pull me over. So throw this email the essay questions. Okay. Oh, set. Okay, so those of you that are in Mr. Torres's class, you'd have the possible essay questions for your exam. Thank you, Samantha, for letting me know that. Okay.